take-home message from this will be how the expert think through this case and what probably they will do. Okay, you can get started.
Hi, so my name is Yusuf. I'm from NUH Ophthalmology. So I'm presenting a case which I've been seeing for about 2 years now. So this is a 79-year-old Malay lady, has been on follow-up myself for, I'm presenting a 79-year-old Malay lady who's been on follow-up myself now for both eyes, not left eye, both eyes, chronic anterior uveitis. I've been seeing her for a year prior to her cataract surgery. And she presented, and I saw her at the onset of disease when she first came with a bilateral anterior uveitis. Throughout the 1 year that I was seeing her, I was controlling her on topical prednisolone acetate 1%, and the pattern of the uveitis was more of a non-granulomatous, normotensive anterior uveitis with very mild macular edema, which improved with just topical steroids. At one visit, about a few months before the cataract surgery, she came in with bilateral granulomatous anterior uveitis, which I investigated, which I'll show you later. So essentially, what happened was that she was also developing bilateral cataracts, and I got her quiet on 1 drop a day of topical Predfort to both eyes, and I listed her for cataract surgery. So I did the cataract surgery for her, and I did the AC tap for viral tetraplex. This was back in December last year.
Before we move forward, just a question to the panelist. Will you do AC tap prior to surgery, during the surgery? How will you go about this one? Is that the best approach? What do you think?
I think the key issue here is the age of the patient. She's 79 years. Okay. Now this is not an age when you would get a viral uveitis for the first time. Bilateral, uveitis in viral pathology, unlikely. So when we think of, viral uveitis in young people, okay. So in this lady, I hope this uveitis antedated or preceded the cataract surgery, that she had uveitis before she
had uveitis for a year before.
So I won't do any tap for looking for the virus. I would do first thing first. If he says she had granulomatous uveitis at whatever stage it was noted, I would think uppermost in mind is the sarcoid. Okay.
X-ray normal, TB negative, contrast.
Yeah, that's what is important. So there's a very recent study on this, where they've looked at old ladies above the age of 60. Okay, and they find that the first topmost diagnosis in that group was sarcoidosis.
So my question here is
chest X-ray normal.
Yeah.
Okay, and then they went on to do CT. CT just had far higher sensitivity in detecting sarcoid hilar lymphnopathy than X-ray chest. So this is so far I don't know what he has.
Yeah, no, correct. So my question here is the chronology of the events. Should he have done the sarcoid workup completely before taking up the patient for surgery, or along with the, let's say, vision is
before.
But he's done it before.
So it was all done. It was all done before. So essentially, when I was seeing her, I was monitoring her endothelial cell counts because I was worried about viral type retinitis, viral type anterior uveitis, and as I mentioned before, the eye pressure was normal throughout. Along the way, with the investigations, the chest X-ray was negative, quantiferon was negative, MANTU was 8 millimeters. Locally in our sarcoid patients, we tend to look for energy. The ACE was 22, Hep B and C were normal, FBC was normal, ESR was 22, and syphilis was negative for this patient.
Why did you do syphilis test?
Missing eye?
No, I mean if she had syphilis, let's presume she had syphilis, she would have it 30, 40 years before, not at the age of 79. Okay, and she would have something, they used to have neurosyphilis, that long term, she would be unsteady gait and she would be, all those neurosyphilis manifestations. So I won't embarrass her by doing syphilis serology at this stage.
We have a patient with our hospital also, and that became a kind of a complaint or a concern case where suddenly that 76 years old lady by one of my colleague was asked to undergo a syphilis, and then patient asked what does the syphilis test mean, And when the patient was told about the detail, the patient was, of course, as Professor Gupta said, was embarrassed. And she said, do you think at my age you are suspecting that, and do you think, and all those kind of questions started. And then later on it became, I don't know what is the rule here, or should we do it or not do it, and
you can't do a test without informing the patient why you're doing it, what it means. You can't do HIV test without explaining to the patient why I'm doing this test, how it will help the patient. Same is here. You can't say that syphilis test I'm doing, hiding from the patient that, well, if serology comes positive, then only I'm going to tell. No, I think we need to be transparent in explaining to the patient any test and every test that we do. We should be able to rationalize it very well. Okay?
So the young
Wait.
What do you see on your AC tab? What type of cell do you see?
I'll put through the case. So the AC test was negative. I did a viral tetraplex of CMV, HSV, as well as VZD with toxoplasmosis as well, and I got a very good volume.
And you did it at the time when the KP was present?
No, I did it during the cataract surgery. I took the opportunity to do it simply because I was going into the eye anyway to remove the cataract.
You were doing the time of surgery?
Yes.
I see. Okay.
Yeah. So I'm going to apologize first because I actually repeated the syphilis later, which was negative again, but I'll go through it. So essentially what happened was the surgery was uncomplicated. The AC tap came back negative. Inflammation was settling down nicely with topical Prep Forte. But what happened was, I watched it very closely because I was, before the surgery, a few months before the surgery, I had only just gotten her macular edema, her anterior chamber quiet, and the macular edema was flat. So I was a bit concerned that it may come back with the surgery. So I did an OCT at week 1, and I found that there was a little bit of edema starting again.
What are these yellow spots?
Exactly. So this was not there before the surgery. Unfortunately, I don't have the photos to prove it, but
did you do autofluorescence?
No, I did not. So this is week 1, and I must admit at this point in time I did the OPTOS, but I did not dilate her because it was at week 1, and I looked at this and but anyway, I think I probably missed it the first week because this was about a year ago. I'm not sure whether what I thought about this back then. And I saw her 2 weeks later. Edema was getting a bit worse. There was still the white patches over there. So at this point in time, because the edema was getting worse, the vision was dropping, I offered her a trial of oral steroids. At this point, she was not responding to the increase in topical steroids. And despite oral steroids, I gave her 1 milligram per kilogram dose, but she was unable to tolerate the steroids and she had a lot of nausea and gastric discomfort. So about 6 weeks after the surgery, we did a posterior subtenon steroids for that eye, mainly for the macular edema. So after the posterior subtenon steroids, 2 weeks later, there was a slight response. 2 weeks after posterior subtenons, 6 weeks later. But now what happens is that the area of suspicious retinitis that we saw started to get a bit worse, and you can see that it got a lot worse. So at this point, I went back to my photos and I realized, I think there was that patch there before, and we got a bit concerned, so we listed her for diagnostic vitrectomy as well as an repeat AC tap for fear that we were missing out a viral retinitis. Now at this point in time, after the AC tap, the vitreous and aqueous tetraplex came back negative, HSV, VZV, CMV, and toxo. There was worsening edema after vitrectomy as expected. You can see this is before the vitrectomy and this is after.
Did you do any cytology or IL profile with pictures?
That's the thing that I regret not doing. We didn't send her because at this point in time, we looked at this and we said, oh yeah, this is a viral retinitis appearance, and because of the posterior subtenon steroids in the eye, that was what we were afraid about. So cytology is something that.
Now my question here is, sorry to interrupt, is how frequently we can repeat AC tap or a vitreous tap? Let's say if it is negative, is it negative forever, or how do we kind of go about it?
Typically, the AC tap will do for viral.
Yeah.
No? Viral.
Yeah,
Now.
viral.
Viral.
Why?
And
You're asking why we do it.
why we do from the anterior chamber?
Is because it is lesser invasive as compared to
Lesser
vitreous.
invasive and more likely that this will be positive.
No,
In cases
no.
of, If you compare it with diagnostic PPV or vitreous tap, then viruses, if they are causing retinitis, they will be more positive from the vitreous. Vitreous is almost double the rate.
Yes.
But you know, putting a needle in the vitreous, I don't do diagnostic vitreous taps.
Yes.
Unless a person has already undergone vitreous surgery. It's a dangerous procedure to my mind, particularly when we have the small gauge, you know, you have 25, 27 gauge instruments available. You can do it, you know, so much easier and without causing any traction on the retina or, you know, causing any iatrogenic problems.
This was a vitrectomy.
Yeah. So, but anterior chamber tab is, you can do it so easily. You know,
Yes.
it's an outpatient procedure. Okay, and if you get a clue from there, you don't have to really go into the vitreous.
Yeah.
Okay, so you do it for the sake of ease. All right. But for toxoplasma, you would not get in immunocompetent individuals, you would not get PCR positive. What you will get positive is the Goldman-Whitmer coefficient, the local antibodies, okay, which you would get it from the in toxoplasma. Toxoplasma PCR would be positive if the patient was immunocompromised in HIV patients and others. You know, then it makes sense to get a AC tap for toxoplasma. But in a 79 years old lady, I think I'm still looking at the masquerade, you know, and the masquerade, they are
Lymphomas.
They'll not be able to come on AC tap. That means
they won't come even on vitreous tap
Vitreous
very
tap.
often.
Proper
So,
vitrectomy.
yes. So anyway, let's hear him.
So at the same time as the vitreous and aqueous sample was sent off, I also sent off blood for all the viruses for both the IgG and IgM. So the blood test came back negative. The HSV IgG was positive. None of the IgMs were positive, but a lot of the IgGs were positive. So the IgMs were all negative. IgGs were mostly positive, which I'll show later. And based on the fact that the AC tap was negative, the vitreous tap was negative, and the fact that we had all the bloods which were negative, which we didn't think was virus. I mean, there didn't seem to be any evidence of virus, so we started to put in an Ozurdex because the edema was getting worse. So we put in an Ozurdex into the left eye, and 4 days later we see a significant improvement. But unfortunately, after the Ozurdex was put in, 3 days later, to my horror, the HSV IgM came back positive. So I called her back, started her oral cyclovir 5 times a day, watched her very closely. So I gave the Ozurdex on this day. This was the day when the IgM was positive, and I started her on oral cyclovir 5 times a day. And I watched her closely from 3rd of April to 7th of April. I saw about 3 times. This was within about 2 weeks. And every time I saw her, she only seemed to be getting better and better. So I thought maybe we're all right. So this was the last review, the last time I saw her before something bad happened. The edema was okay. What appeared to be retinitis had seemed to have resolved. Things were quiet, and unfortunately came the fasting month for our patient, because so there's this thing of fasting month where they have to fast. So she didn't want to come back any earlier, and she started to come back 2 months, 6 weeks to 7 weeks later. Unfortunately, when she came back 7 weeks later, she came to me and said, "I'm sorry, I had blurring of vision for 3 weeks, but I did not tell anyone." And she came in to me, and this is what I saw. So I saw a full thickness, almost like necrosis of the retina. There was a lot of vitritis. Now the vitreous biopsy, when I asked the ER surgeon who did the surgery, he did only a partial vitrectomy. It wasn't a full vitrectomy. So what we see here is an area of what looks like hemorrhage and necrosis. There was, what you can't see here is there's an exudative retinal detachment down there. So this is a sequence of events so far. We did the phaco here. Posterior subtenons went in about 6 weeks later. Saw a patch of retinitis, which diagnostic vitrectomy, Ozurdex, IgM positive, started on acyclovir, and then improvement noted. And then maybe 2 months later, she's seen at this point of ARN. At this point in time, she's on acyclovir 400 mg BD. After 2 weeks of the 400 mg 5 times a day, I switched it down to BD. So at this point in time, I admitted her. started her on IV acyclovir 10 mg per kilogram. I hit her with IVT Foscanet twice a week. MRI brain was normal with no sign of viral encephalitis or lymphoma at that point. I repeated the ACOS test on the day of admission. This had come out to be negative. At this point, there was a concern that the tetraplex may not be sensitive enough, so I sent her for a pure monoplex, which is only for HSV DNA. This was negative. Serum toxoplasma, IgG, IgS were negative. HIV diabetes screen was also negative. This is day of admission. This is day 7 of treatment. There seems to be partial response. Edema-wise, seemed to be settling down a little bit. Sorry, this slides were prepared when I was sending them off for second opinions to other specialists. But essentially, I repeated the HSV DNA once; it was negative. VZAC-D DNA as well. Essentially, every time I gave a jab, I took out ECOS and sent for PCR. So she seemed to improve clinically. At this point in time, the only evidence I had for viral retinitis was the positive HSV IgM. Discharged her with IV acyclovir, converted her to oral bell acyclovir, which she completed 3 months worth. I continued the intravitreal Foscanet outpatient until the patch retinitis seemed to disappear. I repeated the ACOS tab one more time. So after discharge, after about a month of oral bell acyclovir, she came back to clinic and we saw once again active anterior uveitis in both eyes with granulomatous keratotic precipitate. So I took the chance and did the AC tag, which came back negative as well. And at this point in time, I'm scratching my head because I don't really understand why all my PCRs were negative. So I went back to, and like I said, the only evidence I had was HSV IgM. So I began to wonder whether the IgM was a red herring. And so what I did was I actually repeated the HSV IgM because I came across some papers in the past about how sarcoid can get herpes virus related positive antibodies because of the way the immune response is. So interestingly, the HSV IgM is still positive. So this is the first one was done in March. Last one was just done last month. So this is 5 months apart. Back then, HSV IgM was positive. IgG was HSV1 reactive, HSV2 non-reactive. Once again, I get the exact same results 5 months apart. The IgM had not converted, and this is something that we find with puzzling. I've spoken to my ID physicians about it. They can't really explain it either. They say it's a bit atypical, and they begin to wonder, like, once again, whether this is really a red herring. So this was just a few weeks ago. This is the eye as it is now. You can see the exudative detachment down there. Here, everything has burnt out. There is patches of atrophic retina in the periphery. The OCT-wise, you can see just shows very atrophic looking retina. And I also did an FFA ICG. Mainly because I wanted to see, so I didn't really compile this well, but on the OCTs, on the FFA ICG, the main reason why I was doing it is because my concern is that this lady has a cataract in the other eye, chronic anterior uveitis in the good eye as well, and I still don't know what happened to the bad eye. So I've lost the left eye. But my concern now is what do I do about the right eye, which is also rapidly developing cataract. So I did the ICG and FFA mainly to see what's going on in the right eye, especially to see whether there was any particular choroidal disease which I may have missed. Having said that, all the previous OCTs, the choroid wasn't really thick. So these are the FFA ICGs. FFA on the right eye looks quite normal. The FFA on the left eye, I mean, when I look at it, it looks a little bit leopard spotty, but once again, it's hard to tell because of all the so this is just to show the ICG where it seems reasonably normal except for all these darkish spots in the scarred retina. So the concern that I have now is, first question is, how do we explain the persistent HSV IgM? What do you think actually happened in this case? And lastly, what we're actually heading for actually is we're probably heading towards a diagnostic vitrectomy and perhaps even a retinal biopsy. The issue I have with the retinal biopsy is because the disease appears to be quite quiet in the left eye now. I'm not sure how much benefit there is going to be from biopsy, but certainly the rule out lymphoma is one other thing I want to consider. One reason why I'm not I'm partially not that convinced for the lymphoma thing. Is at this point, this is 2 years of initial presentation. I have an MRI brain which is normal. I mean, it's not the perfect test, but it is. I would have expected something else to have shown up by now. But essentially, we will still be doing the vitrectomy to see what happens. But I would appreciate any comments at this point.
Well, first I have to say I admire to presenters a case. A lot of the time, when you first present cases in which we're quite successful, this is definitely a challenging case that you bring out here. I think looking back is always easier because it happened. For me, in general, I tend not to do anything with any type of steroid, either subtenon or intraocular, if I don't know the diagnosis. That's my first rule. I rather use other form to try to bring the edema down, to try to do that rather than steroid, because I think my concern is I have seen enough of cases where intravitreal triamcinolone or something like that, but that's easy for me to say because I'm not in this situation. So I think that this is very good to be blended. So that's number one. Number two is, I think, like I mentioned this morning, at this time, the left eye already have enough damage. And you very rightly so point out that the right eye is of concern. The patient does have persistent IgM for HSV, so for sure, no matter what, the patient should be on a chronic course of valve tract to maintain that. But I would tend to go ahead and get a piece of retina from the left eye to understand whether you see any inclusion or anything inside the retina, because that would then help you more. Because the chances that you bring it back to vision in the left eye is probably low at this moment. So rather than not proceeding to really get an answer, we could consider that.
I mean, I've spoken to the family and explained to them that the main reason for the surgery is not to recover the left eye, but to try and figure out what happened so that at least we can prevent the same sequence of events in the right eye. But oral steroids were not, she was unable to tolerate them, and she's a bit of a frail lady, so we weren't. I mean, we were thinking of IV steroids, but we thought that would be a bit too aggressive. And once we saw the negative PCRs, we were sort of reassured, if you know what I mean. And we had felt that we had ruled out an effective cause, and that's why we thought try a local steroid. But unfortunately, it backfired in that sense. But what we just don't understand is the HSV IgM in the blood, but just nothing negative in the PCRs. I had one PCR before, during surgery, I had one PCR at the time of diagnosis of the ARN which was admitted. So it's just a bit unusual in that sense.
You see, what I might have done differently, I had a couple of cases like this earlier. Based on the picture which you have shown, which looks like post-op at 1 month or so, which looks like very much like a viral to me when you suspect it and you do. So that time when you did, instead of starting per oral acyclovir, which is the bioavailability is not so high, I would have gone straight ahead with the intravitreal foscarnet, thinking that it's a possible viral retinitis, whether ARN or PRN, one of those brackets, and I would have given intravitreal foscarnet and start the patient on per oral well acyclovir because of the higher bioavailability as compared to the acyclovir. But nothing wrong in giving acyclovir. And that too, I discussed with my ID colleagues also. Sometimes when I'm starting per oral well acyclovir, I start them on, let's say, 500 milligram TDS. They usually go up to 2 gram TDS. So I've gone up to my threshold of 1 gram TDS dose. 1 gram TDS is okay because 2 gram TDS gives you the exact same bioavailability of what you are giving intravenous acyclovir of 10 milligram. So that's something that gives you the same amount of dose. By the time the reports comes out, because this report takes a lot of time, the IgG and typically the IgM and all those things. So by the time your report comes out 5 or 6 days, you're covered with antiviral, which you can call it as like what we call it as an TB, as an empirical anti-TB therapy. I call it as an empirical antiviral therapy. And if your results are negative, then you discuss with the patient, though we started you on the thing, everything is negative, we'll probably withhold the treatment and we are not going to continue with the anti-acyclovir or well acyclovir or foscarnet or something. By the time you will see that, because that window period is quite good. But having said that, one thing which does not go completely to the viral thing, if it was to be viral, by 1 week without antiviral and with steroid, it would have worsened like anything. If it was to be ARN and in these patients, what we have started realizing, and we managed to convince a couple of patients after discussing with our RAI team, rheumatology team, is they have a significant changes in their immune system, and a couple of patients have agreed to undergo a bone marrow kind of a test where we do a immune profiling in them, and they show a very significant change in their immune markers. Because why do suddenly HSV1 comes in this age, and that is what we have started realizing is what, though age is one factor which is immunosenescence which is happening, but that is another thing is what's happening in the body. Sometimes there is a immune signature changes. I don't remember the exact biomarkers they do from the bone marrow, but they are doing that, and that helps to kind of accordingly tell them some treatment. I would have gone in this type of case with a clinical diagnosis of viral until unless proven otherwise, and proceeded, and at the back of the mind thinking it is a masquerade. That's just my 2 cents on it. Professor Gupta. Yeah.
Yeah, I'm still not very happy with the IgM positive for HSV at the age of 79. Most of us get viral HSV infection in childhood. So that by the time you are adult, you would be all exposed to virus, because this virus is everywhere. To IgM to be positive, I think I'll like to doubt the test itself. So I will not pay any attention to that. Okay. Number 2, if she developed, and obviously what you are showing here looks like, on the face of it looks like a viral retinitis, okay, which you have shown on OCT also. It's a full thickness necrosis. I would keep in mind the background. Is there somehow this lady, immunocompromised by way of any, we don't know whether she has any underlying malignant pathology. Okay, some of them would have without this thing, and or she's a diabetic, or she has, and I agree with Juan that I would be hesitant to inject subtenon triamcinolone in any patient where I'm not very sure of what I'm seeing, and nor I would give an Ozurdex. I'll hold my hand. So sometimes it's rather than intervene early and act to compound the clinical course of the disease, because we compound it by quickly changing our therapeutic approach. Maybe it's prudent to wait and watch and see how the pathology is evolving, isn't it? So this retinitis appeared in response to Ozurdex. We know with Retisert, there were so many events reported of CMV retinitis. I have seen myself, okay, where we injected triamcinolone, somebody injected triamcinolone and patient developed CMV retinitis. So if I have to think in terms of a viral retinitis, I think I would have CMV retinitis on top of the list. The hemorrhages that we are seeing, are more often seen in CMV than in HSV retinitis or VZV retinitis. So I think we should, and perhaps that's the reason why she has not responded to acyclovir, and we might have given intravitreal. Actually, ganciclovir is a better treatment for, not only takes care of CMV retinitis, it takes care of some of the resistant cases of HSV, VZV viruses also. Yeah,
I think looking back, obviously we're learning now for all of us too. Let's say in that picture on March 19, right? Right there, that picture with that hemorrhage there and that whitish there, do you have an OCT at that time? Because would that show you some retinitis?
It showed a bit of full thickness.
Yeah.
So that's 29. Sorry, just give me a minute. 29. Oh dear, sorry, it's not the video.
If we don't have it, that's fine. Just try to look back now so we all learn about this so that for the future cases. But let's say we see by that moment on March 19 right there, with that heme, with that probably retinitis, the top upper left corner, that's one right there. We probably could hold off on the Ozurdex at that moment because we ask ourselves, what gives you hemorrhage and that type of retinitis? So, as the doctor just mentioned, in general, you don't, that happens whenever you see that whitish lesion with some hemorrhage, retinitis come to front, and obviously we worry about that. So, I think that picture there now, if we remember that, then hopefully in the future we probably pull off.
So the thing is that at this point, I had gotten my PCR results back already. So the reason why we gave the Ozurdex is because we had negative both vitreous and aqueous viral PCRs. And the concern from our end, of course, was that she was rapidly, that there was exudative sort of detachment happening. But the other thing that happened also is that when I went back to the photos, I began to realize that there
There are
was
nasal lesions, yeah.
Yeah, so I'm
They're
wondering what
right
you
from
think
the
of this.
beginning.
Yeah.
So even in March 19,
Yeah,
Charlie was there already there. Just
They were already there and they are in the opposite eye as
You know,
well.
PVRL is known to present as
Yeah.
acute retinosis.
It's-
So,
If you are in doubt and you have done TAP twice, so the doubt is between inflammatory versus malignant, just do IL-6 and 10. So if you see elevation of IL-10, that itself will give you a big clue that what it primarily is.
Yeah, and the thing that's interesting is that after the Ozurdex was put in, there was
You know, lymphomas respond to
To
Ozurdex,
steroids.
steroids. Viral should not. So is it lymphoma? Is it viral? Is it viral complicated on top of lymphoma? There are lots of issues which I don't think we'll be able to answer. But the appearance of inflammation is the opposite side, is a sign of concern while on antiviral therapy. So I would seriously do IL-6, 10 from the opposite arm. But you have to stop steroids before you do that.
and or you should now consider having this. If this is a real patient that you follow, then I would say do as much diagnostic from the left eye we can to answer this question.
yeah. So the left eye, we have FFA ICGs.
You don't have to get its tissue out from it, right?
Oh, except for the left eye. Yeah, correct.
Yeah,
So that's our plan to do that, but it's with some issues because like I said,
now
it's
the
busy.
question is, if you did the retinal biopsy in this patient,
Yes.
two requirements. One is you have to have an expert cytopathologist
Yeah,
or
that's the problem.
pathologist. Secondly, I don't know whether your Ozurdex implant is still working.
It's one up. So we are now to September. So that's about 6 months already.
Okay, already 6 months, so the effect of Ozurdex is already over. Because if the patient is on steroids or
Everything will be
Ozurdex, the pathology again would not show the lymphoma cells. Okay, and I guess you need to see just one lymphoma cell to make a diagnosis. But you have to have, because, I don't know where you are going to, can you tell which area he should pick up for biopsy? If he has to do a biopsy in this patient, what area would he choose?
I think right there, the temporal aspect, right, this area, that would be appropriate. I mean, technically, we usually do it in the nasal side for retinal biopsy for the second unit, but I think right now, that's where it seems to be a lot of necrosis tissue in there.
So what I was thinking was that I do see all these little clumps here, and there are some clumps nasally. So we haven't formulated our final surgical plan yet, but I think just a
Even
tracheotomy
sometimes
under
retinal
air.
biopsy could be negative in lymphomas, so make sure you
I also
aspirate
another thing
the fluid under
As
the
well.
under air. Yes.
So these are layered under the RPE. So sometimes they do infiltrate the retina, but not always. And you might see the inflammatory cells in the retina. Okay, so it's a tricky. I would just wait and watch.
Or just get an MRI done or a neuro evaluation.
That's the other plan. So my last MRI was a few months ago, and on top of that, the patient has financial issues, which is why But, so because I'm actually weighing whether I should, I'm actually considering whether I should
There is
proceed to
something
convex.
happening in the laser. If you see
Yeah.
here, those small little spots.
Exactly.
They are. I didn't see them so clearly before, but it seems they are changing their configuration. I would do that.
I think great. I think that brings like the nuances of managing the uveitis. So this is a typical story of a uveitis subspecialist. Anyway, let's move on to the next case. I'm sure that's equally challenging.
Next one is
Not so challenging, yeah. And yeah, we'll go on to the second case. So there are some learning points, of course, for everyone. Particularly one point which all the experts says is before intervening, particularly any definitive intervention, think twice, thrice, and do not be too trigger finger, and just think. We have also our experiences we've done where we have injected for wrong reasons and we have burned our fingers. So I think just be careful. So let's go on to the next case. Great, thank you.
This one is quite fresh too. I mean, patient just came in about 1 or 2 weeks ago. So it's a 25-year-old Chinese lady, no past medical history. Came in complaining of a left eye, painless blurring of vision for 2 days. No other systemic symptoms. Vision was 621. Normal pressures. Anterior segment was quite quiet, and the color vision was normal. This is a fundus photo of the right eye, which looks quite normal, and the left eye we see these multiple discrete spots. Seen.
Is she a myope?
She is myope. She's a myope. Yeah.
She has that this kind.
Yeah. So that's one of the things we are wondering about. So interestingly, so the reason why I brought this case out is more to discuss the imaging, but just to show you, we do see this. Oops. We see these lesions in the outer retina. There's some subretinal fluid as well. So I did an FFA ICG for this patient, and what I found interesting was on the FFA itself there was some signs of retinal vasculitis in. The ICG in the early phases did not show any evidence of gross stromal choroiditis, as I can see, but in the late phase at 25 minutes, there's this evidence of these large areas of hypocynosance, which I'm interpreting as choriocapillaris inflammation. I'm not sure whether you agree with me with that. But investigations-wise, FVC was normal, chest X-ray, U-film, Hep C, CRP syphilis negative, T-spot TB was negative. MANTU had no elevation, but this was rare after 2 days of oral steroids. So my interpretation of this case is that of choriocapillaris inflammation of one eye. I'm not sure what's going on the vasculitis front. Started on oral steroids and reviewed her 2 days later. She felt better. Vision improved from 621 to 612. This is the OCTs showing an improvement. So this is pre-treatment, where you see that subfoveal fluid, and this is post-treatment. On day 3, where you see it's starting to flatten out. And sorry for the grading images, but one of my MOs just sent this to me via WhatsApp. But essentially, this is at presentation. This one was yesterday. So about 5-6 days after steroid treatment, so the white dots had sort of disappeared. I wanted to ask about what you thought about the etiology behind this case.
No, you gave the diagnosis yourself. This is one of those white dot syndromes, unilateral, young female, is a myope, acute onset of symptom, disappearing over a period of time without any intervention. Now, the typical is the mutes lesion, multiple evanescent white dot syndrome. So where the lesion will disappear, and the fluorescent angiogram actually is a giveaway. The paramacular lesion distribution. Okay, so if we had seen that, they typically describe wreath-like, incomplete wreath or wreath-like distribution of these hyperfluorescent dots. Okay, which stain a little, right? We didn't see actually the angiogram. You focused only on the vasculitis, which is unusual. I don't think mutes would have vasculitis component.
Yeah.
You know, this is unusual. But then, you know, of course, white dot syndromes, you know, there are multiple and different names given, but by and large, I think they represent a spectrum. So you could expect any variable or variations, like the lesions here are more prominent than subtle. You know, in mutes you will have more subtle lesions, and in PIC you would have very punched out kind of, which you don't have.
Yep.
You know, and those lesions will stay. They are not staying here, so they disappear. So your patient is very lucky, I must say. So I would keep it in that spectrum.
The thing that I'm a bit unclear about is where the inflammation is coming from exactly. Is it coming? I mean, it's
This
funny
is
that there's
speculated to be viral now.
Hmm.
That this is some kind of a virus.
Travel history.
No.
Travel history. Because in this kind of thing, come back to the fundus picture, and though there is no retinal hemorrhages particularly, I will always be asking when this kind of lesions comes up is if you suspect one of those viruses, and we have seen Coxsackie and all kind of funny viruses which can come. So just one of the history better to ask is a travel history to any of those things. That's
Yeah, I think Coxsackie is a good differential here.
not for this thing.
Yeah, because usually you would see in small children,
Yeah.
you know, going to nursery class, it's a contagious disease.
Yes.
You know, hand, foot, mouth, you know, they have skin blisters and stuff like that. So it's a acute infection, and in an adult to expect this kind of infection would be, and they typically have the monofocal lesion.
Monofocal.
But you know, multifocal disease is described, and this will leave behind just some traces and will go away. Okay, and so he's right. I mean, these lesions, you know, it's a funny kind of appearance there.
They actually extend-
Central,
they
you
actually
see this?
extend here also.
Each of these is, as a central core is like
Yes, it's
darker.
darker. The central
And,
core is empty kind of thing.
Yes.
Something different, like a pimple or blister kind of thing.
Yes.
But definitely it is a deep retinal or deep retinal, not choroidal kind of thing, but
No.
definitely in the outer retina
Yeah.
and all. One thing, I don't know whether ICG is not done in this.
ICG was done. So the finding about ICG is that the
Yeah.
ICG is
patches
not
are
really
a
anything.
bit different compared to where you see the white spots. If you see,
Yeah.
you know, so it's a bit. I'm trying. The reason why I was confused is I was trying to interpret what this means when we see
And
later on.
that vessel which is leaking on the FA in 6 minutes, what happened to that particular, the inferior vessel? Is it small bit of leak is there on that?
It's a small bit of leak, but
It remains like that.
Remains
It's
like
not
that,
because that's showing there is some kind of
the FA
inflammation.
was quite clean actually.
Was quite clean.
I wasn't expecting to see
You
this. I
know,
was-
this
yeah.
kind of a situation, you know,
Yeah.
it doesn't point to any specific diagnosis. But my best bet would be that she would fall in the spectrum of mutes.
One of those
So if
choriocapillaritis.
you think of like that, I mean, in this case, the patient have subretinal fluid, but the retinal fluid, so steroid was given. But if you think that it's along that line of revival, would you have treat?
That's
Sweet. You know, maybe one would see for a few days, you know,
It might
evolution,
spontaneously go.
evolution of the lesions, because
The lesion, I think, like I think in this case, the clinician is under the pressure because the OCT showed there's a bit of fluid in there, and so whether or not, I think that's that, because if you just see the wreath along without the, I mean, if you just see the lesion along without the maculopathy, without the fluid there, probably you would have wait a little bit more, right? I think you, and I think that's maybe reasonable.
The other thing that was unusual about this case was that the clinical history was from the onset of symptoms until she saw me 2.5 days later, she was actually getting worse every day, which is the other reason why we began treatment, which is a bit atypical for mutes, and it is my limited experience.
You should do blind spot and Rajneet.
Visual field.
yeah, that's where
I
you
think
should
that's-
have this swelling and staining of the disc. So
Other thing we started doing with Professor Graham Holder here particularly,
Yeah.
this kind of cases,
Yeah.
electrodiagnostics will be quite useful in understanding how much, whether it is RP epitheliitis or in this kind of thing, you know, that will tell us a little bit more about the level of the lesion, if not the etiology as such.
I'm planning her for electrophysiology at some point, but with the steroids on board, I'm not sure.
Were there any vitreous cells?
No, not that.
No vitreous cells at all. and that's difficult. Don't you
Also,
think,
sorry,
can it be a spectrum of a zoo?
There were visual cells as well. Sorry, sorry.
You know, they typically
This is
the
not
zoo
laser.
would have photopsia.
Yes.
This is not
Photopsis.
laser.
It is not.
So it's not. And clinically you
Quadratic.
don't see anything.
Yeah.
And only when you chart visual field you will see the scotomas or the visual field defects. And only later on you might see subtle changes in the fundus picture.
Yeah.
So clinically here they are well formed, these lesions. I don't think they are the ones described as root lesions.
But for a lot of the young ophthalmologists sitting here, these are not the cases where you should be doing any kind of injections in the eye, anti-VEGF, because we do see once in a while people get anti-VEGF, Ozurdex in this vitreous tap and ECW. I think this kind of cases definitely not, and particularly in these cases you should be very careful.
But you know, my message to young people would be that you must document these patients. Document them, you know, like he has done. Okay, and even if you are not able to do, you know, they are the ones which teach you forever. Okay, how the lesions are evolving. So these cases may not mimic what's given in the books, but you have to learn from your own kind of patients, what you're seeing in your own setting, and make an archives of your own patients, you know. That's how you will actually learn from your own patients.
We have international expert Dr. Ivan Ho, who is giving some talks in Pentoxian Hospital, and one of the things he was sharing with us, which was very jokingly, he was sharing they had a complication, something post-laser hyaluratomy. It was bleeding like anything, and then they called their supervisor mentor and was asked what to do. He said, take pictures, take photos. I think that was one of the advice. I think, but yeah, we do record all those cataract complications, because cataract complications do not come. I think these are the kind of cases one should document. Also try and attempt to publish it also, because we learn also a lot from publications.
Yes.
So that's just not for presenting, but I think it's also for learning a lot. Okay, great. We'll invite Dr. Chittaranjan to present the last case for the day, and then we'll give everyone some bit of rest so that tomorrow they can come fresh with. Okay, Dr. Chittaranjan comes from South India.
Isasu for giving me this platform. Actually, my case is a combination of clinical manifestations of glaucoma, uvea, which landed up in VR surgery ultimately, but still remains undiagnosed. Actually, the case was a known case of a one-eyed case. One eye vision was already lost 16 years back. The patient told some vague history of trauma, which he was not sure. And the other eye was on glaucoma medications, maximum glaucoma medications. Pressure was 52. So there was no systemic history, diabetes mellitus or hypertension, no other systemic history. And coming to the antecedent examinations, both IMSC was there. And so keeping the IOP in mind, the patient, this is the clinical picture of the patient. Left eye, this is the eye where the patient gave a history of trauma, and this is the right eye. Point-8 cupping was there, though it is not very evident from here. Point-8 cupping was there. So the patient was advised and underwent phaco, IOL, and trabeculectomy in the only eye the patient had. And pressure was 26, 28 kind of. The best corrected vision in the eye was 618 when presented, but it was degree to 636, and pressure was 26, 28 kind of. So post-op around 1 month, the patient was advised and underwent blame needling with 5 FU. Then after around 3rd week, the patient was referred to retina with this kind of picture. There are some ILM folds inferiorly. This is a close-up picture. So So this is the ultrasound picture where you can see some choroidal thickening and retinal, some shallow retinal
Was
detachment.
there any scleral thickening?
RCS thickness was increased, but it was not very kind of 1.9 kind of. It was not very uniformly thickened over there. So we went ahead with FFA, where you can see initially some diffuse leakage was there. You can see here this is in the periphery some dot hyperfluorescent lesions were there. So this is the other eye, the eye which had history of trauma. This is that eye, the trauma eye. So we had no clue actually whether it is a posterioritis, uveal effusion syndrome, or same pathology as the other eye which was not diagnosed, or it is sympathetic ophthalmia kind of. So we did a urea workups with all the system workup. We did the complete blood count, blood glucose, renal function test, PSA, and CT scan was not evident of any active or healed lesions except some emphysematous blaze noted in right lung. And the patient was started on 30 mg oral steroids with topical steroids. The IOP was around 16, somewhere varying between 11 to 16, and repeat FFA and ICG was obtained. These are the pictures with the ICG pictures that you can see. So then after 1 week, the pressure decreased to 6, 6, 9, kind of little low, and patient's vision dropped drastically to hand movement. And he developed actually RD, CD, and in the last visit, patient had retinal detachment. There was no other option. Patient underwent surgery actually, vitreous surgery with silicone oil. So at the final visit, patient has the vision of hand movement only. So actually we are clueless what is the diagnosis. It all followed after the blade needling.
So the last step, the surgery was then there was a hole created or drainage of the fluid, or how did you, or
No,
you already did, you have not done it yet?
We did not do the CD drainage. Actually, when initially it presented with RCS thickness and CD's shallow RD was there, we were planning for CD drainage, but the patient presented with retinal detachment, and we went ahead with.
Was it a reg RD?
Yeah.
No.
It looks like uveal effusion syndrome to me. I would, as a first step, do MRI to look for the scleral thickening of this eye and the opposite eye. How much was the X-ray length?
21.9. IOL power was plus
21.9.
22.5.
So glaucoma
IOL power.
could be due to the association of a UES. So my first thing would be that. Second one, posterior, but the left eye doesn't look like posterior scleritis somehow. I would go for UES. I would do MRI to look at the scleral thing.
Dr. Chitranjan, I go back to the fundus picture and original before the surgery. You have
This picture,
This one, the fundus picture.
this is post because originally what was the, it was absolutely normal when you, because when you plan for a primary open glaucoma surgery because of the higher pressure, I am even thinking what was the indication of POG, because it was on maximal therapy and the visual fields were quite poor, right?
Yes. And
Okay.
pressure was 52.
And this eye was not having any of the findings which are there in the left eye. And left eye was probably history of trauma.
Trauma, histotrauma and PL negative because no perception.
No light perception, and that time you took up for the surgery, and immediately after the surgery, show me again. Yeah, and then next slide. You did 2 FFA very quickly, right?
Yes.
Within 1 week. What was the reason of repeating that FFA and IC?
No, like actually, when the patient actually came, 2 people, Dr. Lavanya and myself, my colleague Dr. Lavanya, both of us were following. So when I saw the next time, first time ICG was not done. So ICG we did and simultaneously ICG and
So I think one of the things is that how do you investigate cases like this at this stage? So one thing is that once you see, you document whatever the fundus picture, probably do the non-invasive test as maybe ultrasound B scan will be ideal thing to pick up whether it is exudative, and sometimes some experienced ultrasoundologist can pick up whether there is any rheumatogenius or anything like that. I will also look for a T sign and look for a choroidal thickness on the B scan.
He showed ultrasound.
Yeah,
Right?
so that's definitely we need to do that, and we have to think about why, if we at all want to do FFA, what is the indication of doing FFA and all those things. But good, and then I don't know what do you think, Professor Gupta? Yes. Anything we are missing here?
No, I think the differential diagnosis is all what we have discussed. If this patient was younger, I would keep diffuse choroidal meningioma also the differential, because there's a big series reported with these patients can present with glaucoma, acute glaucoma, and particularly after filtering surgery, they go into massive choroids. And from our department, they have reported now a series of patients where they used beta blockers. But that's a younger kind of 67 years. I would expect meningioma. The picture doesn't look like meningioma. It's more
This
like
patient was on Simbrinza medical. It's inzolamide and
Benzolamin.
So
Simbrinza.
that's like the common
Yeah.
yeah.
So
Will this picture, I mean, he has not described any cell yet, but could this eye be a case of an SO? I mean, the AC reaction does not.
Yeah, you're in a way you're right. The angiogram looks like that at this stage, but to believe that it got precipitated by needling, and there is already history of trauma, and yeah, it makes sense. Needling and glaucoma surgery was
Glaucoma surgery was
done
1 month before.
1 month. Yeah.
But the eye,
The other eye is also showing activity,
Yeah. So that eye that had trauma that.
So if you show that angiogram, I think there's a point, absolutely.
Has this
Yeah,
patient?
you see this.
Yeah, so that and the one before that can be. Has this patient ever been treated with
We
systemic?
don't see such diffuse changes in the peripheral sympathetic ophthalmia.
This leakage is there.
We generally see them in the posterior pole, and
Yes.
I don't know, this is too diffuse.
We started systemic
Yes,
steroids
yes.
30 milligrams after maybe 3 weeks. Started 30 milligrams, not a very high dose like.
If
Just show the
there's no
picture of the other eye. Left eye you have.
Yes, sir, yes.
then like
You had the, yeah, this is showing, and later on this fluorescence is not seen.
Yes.
So there is some activity even in the left eye. So it will be a good diagnosis.
We have put it as differential.
Oh,
He's
yes,
put
yes.
sympathetic ophthalmia.
No, he's put all those.
No,
Yes,
three
I
only.
go there through less.
I would, I mean, the 30s, if there's no major contraindication, I would go with IV and really see when you maximize that dose to see if there's a response. Because part of that is that and along with indication, that's how they have that you will see some response, but you treat it fully and see what happens with that. Because this is again a one-eye patient lab, so we try to maximize, do everything we can to save it. Because right now it's hand motion.
Hand movement.
Another thing is that don't be chicken-hearted in treating that like 30 milligram, because you are neither there neither here. Once you decide to give for the oral steroid, at least go for the maximum possible dose, whatever can be given.
I think also important is because your differentials are such,
They're
one of
non-indicated.
which is not a contraindication for
I
steroids.
agree.
So in such a situation, you can go
Hard.
full flow. But if you had viral as a differential diagnosis, then you need it.
Definitely you've got a good choice that you're not given for intravitreal immediately, but 60 milligram or whatever 1 milligram per kg body weight should not be contraindication here, and that would have given a clue whether the patient is responding or not.
Yes.
Hmm? Very important.
So now at this stage, can we step up again, kind of?
Yeah, you go for a maximal oral whatever they use. Definitely.
IV.
IV.
If you are thinking of sympathetic, then
Yes.
you declare a war.
Okay.
This is the only eye.
How the vitreous cells are there? Intravitreous cells and
No,
posterior cells? That's something you watch out for. Because it
Yeah,
can
you know,
Not-
I think a series we reported, long time back in eye, where it
quite
presents without inflammation, just in the retina, in the posterior segment, and similar kind of picture.
because the classical teaching is that the first symptom is blurring of the vision, near vision, and the first sign is retrolental cell. That's the classical teaching.
I think that's wrong.
Sympathetic ophthalmia.
Yeah, I think that's a wrong teaching. Okay, we have seen so many of these patients just presenting as what we used to call posterior sympathetic ophthalmia
Sympathetic.
without any inflammation. It takes, it's so simple. Rupesh,
Yeah.
it's so simple. The cell will take some time to move into the vitreous cavity, from vitreous cavity to come into the anterior chamber. Whereas when the choroid is getting inflamed, that is where you will pick them up first. So by angiogram or by OCT now, so when the patient is symptomatic, the first thing would be in the choroidal swelling. Okay, much before the cells will start appearing. No, but you agree with that?
I agree. Basic question. How do you differentiate choroidal from scleral thickening on E-scan?
How do you
That's
differentiate?
what I said MRI.
Alright, so you kind of
Scleral
differentiate.
thickening on MRI shows very well in uveal effusion and nanophthalmos and all, and you can look at both the eyes simultaneously.
You can measure the scleral thickness. Okay, and these are typical. They may be nanophthalmic, they may be short eyes, or they may have just the short posterior segment, or they may be even normal. Okay, but thickness is all these patients will show a thickened sclera. Okay, which you can do it on MRI is the best way. They won't ultrasound and all these are very, very insensitive technique.
Subjective
Yeah.
importance.
Does the patient
But-
have
When,
does the patient have any symptoms?
no, like effective is investigated.
But one thing you can always do in all these posterior uveitis patients is the enhanced depth imaging OCT to pick up the choroidal thickness and all that can be nicely shown.
Yes, that
But
is
nowadays all this the swept source and all the kind of different OCT, you can really see the choroid much better. I think this kind of cases always you should document, and that can be useful. How much is your choroidal thickness and all that.
So I'll put my bet on Cohen's diagnosis, sympathetic. That's the best fit as a.
We'll call the patient and start on aggressive.
Yeah.
Yes, that's the message.
Do MRI before starting
Focus on
steroids.
Okay. Thank you, Dr. Mishra. Thank you for presenting. I think thanks to both the delegates for